Care of patients with disorders of the gallbladder, liver, and pancreas. Cholelithiasis or gallstones develops when the balance between cholesterol, bile salts, and calcium in the bile is altered, and these substances precipitate. When cholesterol precipitates, a stone may be formed. Tiny stones pass into the bile ducts where they can become lodged and obstruct bile flow. When stones lodge in the common bile duct, the patient has cholelithiasis. Cholesterol-lowering drugs increase the amount of cholesterol secreted in the bile. The symptoms will depend on the obstruction to the bile flow and the extent of the inflammation of the gallbladder. The absence of bile in the intestines results in clay-colored stools that float because of undigested fat content. If a duct is obstructed by a stone, obstruction of bile flow by stones in the cystic or common bile duct causes strong muscular contractions that attempt to move the stones. Severe pain for the individual may be triggered by a fatty meal. Nausea and vomiting, fever, and leukocytosis occur with cholecystitis. The pain may be referred to the right clavicle, scapula, or shoulder. As bile backs up into the liver and blood, jaundice will occur. The most common symptom in an acute flare-up of chronic cholecystitis is unbearable right upper quadrant pain, known as biliary colic. Gallstones within the gallbladder with obstruction of the common bile duct and cystic ducts cause severe pain. Cholecystitis is an inflammation of the gallbladder. A low-fat diet, loss of excessive body weight, and restriction of alcohol intake are recommended. Meals are to be spaced so that no large amounts of food are put into the intestinal tract at any one time. An endoscopic retrograde cholangiopancreatography, or ERCP, may be performed to remove stones obstructing the common duct. The gallbladder removal is indicated for patients with ongoing symptoms or complications. One drain that might be inserted is a small T-shaped tube known as a T-tube, placed directly into the common bile duct during an open cholecystectomy. This tube must be patent at all times and connected to a small drainage bag, known as a bile bag. The nurse will teach the patient to report the following signs and symptoms if they occur: redness, swelling, bleeding, or bad smelling drainage from the wound site, no bowel movement or gas for 3 days, or watery diarrhea for more than 3 days, bile-colored drainage or pus from the surgical site, severe abdominal pain that is not relieved by medication or that is getting worse, nausea, vomiting, chills, or a fever that is greater than 101 degrees Fahrenheit, light-colored stool, dark urine, or yellow tint to the eyes or skin, which may indicate an obstruction to the flow of bile. Liver cells are damaged either by direct action of the virus on the hepatocytes or by cell-mediated immune response to the virus. Hepatitis viruses cause extensive inflammation of the liver tissue. Hepatitis A and Hepatitis E viruses are transmitted primarily by the oral fecal route. Hepatitis B and C viruses are transmitted by parenteral routes and sexually. The hepatitis D virus coexists with hepatitis B or C virus and it is transmitted in the same way as hepatitis B or C. The nurse will often presume that liver disorders are associated with jaundice. However, viral hepatitis without jaundice, enteric hepatitis, is 2 to 3 times more common than viral hepatitis with jaundice. The liver can regenerate. Non-pharmaceutical treatment is supportive to enhance the patient's natural defenses and promote the healing of the liver. Hydration, sufficient rest, and adequate nutrition are the goals of nursing care. Vaccines are available to provide active immunity against hepatitis A and hepatitis B. Hepatitis is an occupational hazard for all individuals who have direct contact with patients or surgical and diagnostic equipment. Standard precautions must be observed. All healthcare personnel should be immunized with the hepatitis B vaccine. When a patient with viral hepatitis has been admitted to the hospital, the infection control professional must be notified. Hepatitis is on the Centers for Disease Control and Prevention's National Notifiable Conditions list, and all facilities and healthcare providers are required to report cases. Cirrhosis is a progressive chronic disease of the liver. Normal hepatic structures are destroyed and replaced with fibrotic tissue. Fibrous bands of connective tissue develop in the organ and eventually constrict and partition the liver tissue into irregular nodules. When liver cells begin to degenerate, the blood vessels within the liver also fail to function. This causes an obstruction to the flow of blood through the portal circulatory system, causing portal systemic hypertension. The treatment for cirrhosis is to stop damaging the liver, decrease any further damage, and to help the patient manage their symptoms. Caput medusa are bluish varicose veins that radiate from the umbilicus. Fluid retention in the right hemothorax or ascites can limit the expansion of the chest and cause dyspnea. Peripheral edema and ascites, skin lesions, jaundice, pruritus, bleeding disorders, endocrine disorders, and peripheral neuropathy all can occur late in the disease of cirrhosis. Spider angiomas may appear on the face, neck, upper trunk, and arms. Excessive high levels of biopigment known as bilirubin are present in the blood. The first signs of jaundice are usually seen in the sclera of the eye, icterus, which takes on a yellow tint. In people with dark skin, jaundice is best detected by checking the buccal mucosa, hard palate, palms, soles of the feet, sclera, and conjunctiva. This concept map is a relationship of the systemic portal hypertension and ascites in liver cirrhosis. When liver cells begin to degenerate, the blood vessels within the liver also fail to function, and this causes an obstruction to the flow of blood through the portal circulatory system, causing portal systemic hypertension. The altered vessel permeability and fluid leakage into the abdomen result in ascites. More fluid is contributed as damaged liver obstructs the flow through the lymphatic system, and the protein-rich fluid collects in the abdomen. The damaged liver has a limited ability to synthesize albumin, which causes the osmotic pressure within the blood vessels to fall. The change in osmolality allows fluid to leak out of the vessels into the tissues, contributing to edema and providing more ascites fluid. Another mechanism that contributes to ascites and edema is excess circulating aldosterone, which is not properly metabolized by the damaged liver. The excess aldosterone causes sodium and water retention. Bleeding from esophageal varices, which are dilated, distorted, engorged veins, is a major complication of cirrhosis. They are the result of portal congestion and hypertension. Portal systemic encephalopathy or hepatic encephalopathy is another dangerous complication of cirrhosis. Encephalopathy is directly related to liver failure and caused by a buildup of ammonia and gamma aminobutyric acid. A liver transplant is considered for patients with progressive and advanced liver disease that does not respond to treatment. After surgery, a T-tube and a bulb reservoir drain will be in place in the abdomen. An NG tube may stay in place until the bowel function resumes. The patient must take cyclosporine for life to prevent rejection of the new liver. Any right quadrant or flank pain, increasing jaundice, fever, and changes in stool as well as urine color may indicate organ rejection. The patient will require close medical supervision after discharge. Primary cancer of the liver in the United States is rare. Hepatoma usually develops in people who have cirrhosis. If no distant spread is found and there is no lymph node involvement, surgical resection of the liver may be attempted. Sitting and leaning forward may ease the pain of pancreatitis. The severity of the pain may slowly decrease after 24 hours. Eating will make the pain worse. A major nursing action is to be supportive of the efforts of the individual to abstain from any alcohol. This is the pathophysiology of acute pancreatitis. Cancer of the pancreas is often fatal within 1 year. It is usually in an advanced state when it is discovered because it is asymptomatic in the early stages. When the disease is advanced, jaundice appears along with dark urine and clay-colored stools. There is also glucose intolerance. Surgery is routinely used to relieve symptoms of obstructive jaundice, severe pain, or other complications. High doses of opioid analgesics are usually required to keep the patient comfortable. Drug dependency should not be a concern for the nurse. Treating or preventing malnutrition is a major goal. Enteral feedings may need to be given into the jejunum through a jejunostomy. Total parenteral nutrition may be needed to provide adequate nutrition. Nursing care is geared toward managing the severe pain and managing any side effects of the treatment.